Case study here, somebody worked with quite a bit, asked him for some help. So here's the deal. Professional basketball player, very high level, one step below EuroLeague. A history of fit, but not always doing the stuff that you would recommend to do from a nutrition or a fitness level. Remember, basketball players can get into shape just by playing. So when I say fitness, I'm talking about strength training. I'm talking about some of the special exercises for movement that may have value to him, not talking about conditioning. No one plays basketball at a high level if they can't get up and down the court. But that's important in this, as I try to mentor / help my guy appreciate how to handle this situation and find out what's best for him. So he fell, and the indication was shoulder pain. And there's a lot to unwrap here, but my guy sent him for an MRI, and which I've made it very clear I don't think that's a bad idea, but this one was a bad idea because in the construct, in the schema of which he did refer him for the MRI, he kind of gave up control or management of the situation. Control is a little bit more dangerous to say. Control, not such a great word, but management. Because again, he's just referring to get the image. And he said, I said, well, why'd you do that? He's like, well, I think it's a good idea to understand the degree of what we're dealing with. I said, that's perfect. Again, how do we handle this in the future is one thing. But again, this is more of a mentoring recount rather than a pure clinical case study. So it comes back, AC sprain, no big deal. He fell, okay, not to be shocked, especially if you fall straight on your arm. And some old supraspinatus partial thickness tearing, okay? Remember, this is an elite basketball player. But number one, the supraspinatus was always there. And we do know historically from this player that his shoulder mobility is clearly compromised. And to now know that it's an old supraspinatus injury that healed but didn't really recover efficiently, we got to go to direction of fibers. We got to go to pressurization. We got to go to breathing if that's a goal to rehab from the supraspinatus piece. AC joint, whatever. And he says, the physician, and this is where his original question was, suggested hyaluronic acid for the AC and nitroglycerin patch. And I'm like, okay, well, this is another country, so maybe those things are more common. Clearly, if we look at the purported scientific merit of nitroglycerin patch and clearly hyaluronic acid, yes, these do have value from a regenerative standpoint, for what at least they're supposed to do. I've never seen a grade 1 AC sprain being recommended either of these things. I said, in fact, if it's a sprain and we're kind of in a very compacted time frame, probably just do a cortisone shot and be off on your way. Like, I don't think that that's a perfect idea, but if we're going to think of anything, are we going to think of PRP for the tendon? That's not the nature of this episode. We're looking to get ready to play. I said from a hyaluronic acid, you'll see that a little bit more often, but not for a ligamentous sprain. And if that's a limitation of my knowledge of HA, then you're going to see that more with degenerative issues, etc. So I guess there's no reason to suggest hyaluronic acid can't be used for more of these soft tissue types of things. It's just not what I'm seeing. And it might be a limiting factor because I can see where the physiology that's purported from that. But nitroglycerin, I mean, obviously, yes. Nitroglycerin, we're probably, and I don't know, I'd have to have them memorized, all of the different, I don't know what the right word, components, where the nitric oxide then becomes this, which then becomes this, which then can have collagen synthesis impact. Okay, use it. Like, I'm not sure if that's what it does and there's any downside. What is really, the question here is that even if those things are going to have value for you, everything in this case, and probably in anybody's case, really just is going to track back to how you train, how you eat, and how you sleep. So now the training piece would be what we would do from a rehab and or training standpoint, fitness or recovery, rehab, whatever you want to call it. And I said, like, what else do you have here? Because we also have to then look at, while the MRI is showing us some very, very real things at the AC joint, we do have to be somewhat cynical on the relevance of how that is being perceived as a threat and thusly pain. What do you mean? You have pain right here. There's a lot of other stuff that are near there, and let's build it out. I mean, we can be real rudimentary and just stick your thumb in the infraspinatus and see if your pain changes. And maybe even sticking your thumb in the infraspinatus wasn't a chronic trigger point impact, but just that ischemic release had this increase in blood flow, which then allowed, a little bit of garbage in and a little bit of garbage out from that part of the shoulder. All of these things are very possible. So, in building out a thought process, I was telling my guy, like, we got to go by what we say. Okay, fail, my shoulder hurts. We don't know anything about what you do yet, and then we know the truth. We know that there's a supraspinatus chronic issue and an AC joint acute issue. So if we're going to skip steps and not miss anything, and we're in this 7 to 10 day period where this individual needs to be as close to full speed as possible. I'm sorry if I left that out in the beginning. I'm like, okay, just give them Eldoa for the AC joint, bang. Eldoa for the SC joint, bang. And Eldoa for glenohumeral joint, and try some different patterns. I don't know exactly, without a full evaluation, where the supraspinatus would guide us, but just try those 3 things and see if the shoulder feel better. Wildly incomplete, but might be along the way even if we did do something complete. And he said, okay, that makes sense. What if I were to be complete? I said, well, then you gotta do your evaluation. You've got to, however you want to do it. And when you talk about specifically Eldoa and you talk about the ardent, like by the book, there's chains of fascia in the body that would qualify to have impact in certain areas. Well, again, I'm not an ardent user of anything per se. We're going to come up with our own chains. And the way we would do that is kind of take like a line, and then you try to mash them all together. And it's just how I think about from things, what you say, what you do, and the truth. And somewhere when you bring them all together, your approach will start to begin. Then, what are you actually going to do about it? You're going to then literally make like a list of everything in the body that hurts. Then you're going to make a list of everything in the body that doesn't necessarily hurt, but doesn't do what you want it to do. Okay? Then you're going to make a list of everything in the body that had a previous injury. And we're going to then evaluate locally, because we're going to be under the assumption that the tissue healed, but not a complete recovery. And then in the 4th lane, we're going to write down everything that we know to be typical injury patterns for this particular sport or the position in that sport. So basketball, all 5 guys are the same. What would we look at? You could make it as little or as much as you like. Ankle sprains, Achilles, tendinopathy, patellar tendinopathy, and low back pain. You do not typically see upper body injuries in basketball, because if they were limited in how they were able to tolerate load and stress to their upper bodies, they probably wouldn't be a basketball player. So that's not. So now you've got 4 lanes, and then you mash them all together, and you start to see where the body's telling you a story that then tracks back to solving whatever your limiting factors are for pain or relevance for the shoulder, even if it wasn't painful. If we take a different approach, which would maybe be more illustrative, because that's exactly how I would try and teach this. We'd write everything down, and then we'd be like, okay, treat this, this, and this. So once you get all those things, you're like, okay, this is painful. All right, now, AC joint. We already talked about Eldoa for the AC joint. Well, if there's an Eldoa, then there's a pumping, okay? So we can do pumping, and when I do my hands like this, the technique that I'm familiar with is you can pump the AC joint and the SC joint at the same time. I don't know that there's another approach. Clearly, there's other types of AC joint manual therapies, but this is what we're talking about because I started with Eldoa, okay? Well, you got the clavicle. Well, can the clavicle move? Well, if it moved too much, maybe there's spasm, and doing a little bit of mulligan with one of those sponges might have some use. Well, you've got the subclavius right there. You got the pec minor that's very close by. You got the pec. You've got all the rotator cuff. Start just palpating, maybe needle some of those spots, just knock them out, just pull the rug out right away and just constantly restart your analysis by knocking down all these pins. You got the biceps tendon, you got a 4 rotator cuff, you got the pec, you got the lat, you got oh, hey, so if we're going to talk about the pec minor, well, then you got the ribs. Well, you got the ribs that have intercostals that go through these. This is how you start to build out your chain. Then you go the other direction. So if it hurts right here, it's got to be C5. Well, if it's C5, that's next to C4. Then you get next to C6. Okay, what else is C6? Good news, a lot of the tissues that we already named are also C6. So it doesn't mean you have to treat all of them, but you do need to look. It's like you're just looking for clues, and you now have a rationale as to why you're looking there. And in fact, if you say it hurts right here, that can only be because your brain received a signal, and then your signal was interpreted, good, bad, indifferent, and that's why you say pain. So creating those types of, once you have your list, and then you do whatever, it's palpation, maybe you just needle it out just for the hell of it, and you might really have a completely new environment to look at. And he's like, wow, that makes a lot of sense. Because now you're not only just treating the area, you're truly being interregional, you're truly being regional, and you're being local. And there might be a different combination thereof as different components kind of come together. I'm trying to think of this athlete and what other injuries he may have had. I'm sure there was always back pain. I do remember he had this weird glucose response where his glucose would go up with exercise. That's something other people would handle. I don't mess with potential metabolic pathology. And then we went into, hey, maybe, figuring out ways to get better at when that referral does happen. Then how can we, try to stop this from happening? Not because nitroglycerin and or hyaluronic acid were such off the wall, like ludicrous, disgraceful options, but now you have somebody who didn't even care that you referred him, didn't even care that you were also working with this athlete, didn't matter, so that we just kind of want to say this guy should be off the list. We need to refer to someone else who's going to kind of push and pull with you rather than maybe arguably have some good options, but just not the ones you were talking about. Because as we discussed more and had a clearer view, I'm like, yeah, I probably wouldn't have even sent him for MRI. Look, it was a grade 1 AC sprain. If you weren't sure that's what it was going to be, then of course you should be sending it. We need to make sure that there was nothing more serious than that. So that's not the end of the world, I'm not banging on my guy. But if I didn't send him, then I would probably have even more time to accomplish what we would want to accomplish with those 4 categories that develop as many different chains of treating as you would need. And of course, whenever there's therapy at a segment of a chain, if that therapy has an immediate dramatic response, you automatically start to build out your exercise plan. Not only does that plan go live side by side with lateralizations, that's the beginning part of all of your potential regressions for the movement piece rather than just the fitness piece. So, as usual, talking really, really fast, but this was a good opportunity because the actual injury and pathology really wasn't that big of a deal. So it's a good opportunity to then figure out your list of everything that hurts, your list of everything that doesn't work right, your list of everything that would be from a previous injury, because we're going to assume that they're not fully recovered, and a list of everything you typically see in that sport. Then mash them all together. You'll probably get them out of pain as long as it's not a significant chemical response, probably pretty quickly, not because you're so great, not because you did magic, it's because you just asked all the right questions.